conducting a hearing for Friday, February 5th, 2021, 8:30 a.m. agenda. The chair would like to highlight to everybody that there is a 2-minute testifying window. And we ask you to stay within that. What will happen is, as your time comes up, now that I have my own countdown clock, I will warn you when your time is about to expire. When your time expires, I'll be asking you to wrap up, and then the video will move on. Let's see. We all good to go? Okay. So first measure, HB 826, relating to electronic smoking devices. The Attorney General.
Good morning, Chair. Can you hear me?
Yeah, go ahead. Again.
I'm not sure if you can hear me. This is Richard Stacy.
Please proceed.
Okay. Richard Stacy from the Department of the Attorney General. I did submit testimony in opposition. We do appreciate the seriousness of the vaping crisis, and we've worked with the advocates and Department of Health. The issues are more technical with this bill. The 1998 Tobacco Master Settlement Agreement requires us to strictly enforce as to cigarettes. And this was from 1998 and long before e-cigarettes. So the vaping crisis is very important, but it's not under the MSA. And we are tasked to strictly enforce the MSA, or Hawaii faces the loss of large amounts of the MSA payments, which we get every year. And that pertains more to Section 5.2 regarding expanding the MSA, the Tobacco Enforcement Special Fund. As to Section 5, it has the same risk of taking away from the MSA enforcement, and it's not quite clear on the funding. But it's all in my testimony, and I'm available for questions.
Okay, thank you. Budget and Finance provided comments. Department of Health. You need to unmute yourself.
Thank you, Chair and members of the Health Committee. I'm Lola Irvin, representing Director Char for the Department of Health. And the department provides comments on HB 826, of course, deferring to the Attorney General's office on the fiscal implications and enforcement, much of which is stated through the FDA. So we do note that the preamble makes comment about the proliferation of e-cigarette products and the pre-market authorization. We want to note that these products, even if they've submitted applications, they will have to undergo rigorous scientific review by the FDA to determine benefits versus harm, and that has not been completed. Also, that the preamble also talks about the loophole, and it correctly states that indeed private delivery systems can still deliver e-cigarettes to homes in Hawaii, and so that is a big problem in that in Hawaii, e-cigarette use has increased from 25.5% in 2017 to 30.6% for high school students who say they're regular vapors. So the other part is in Section 4, from a public health perspective, we do want to note that youth penalties are not proven methods for reducing smoking or e-cigarette use. So we are concerned about that. We do thank you, though, for the attention that you've brought to the e-cigarette issue and the fact that we do still have a crisis of e-cigarette use by our youth. Thank you for the opportunity to provide testimony.
Okay, thank you. We have testimony submitted by Hawaii Primary Care Association, Hawaii Public Health Institute, American Heart Association, Volcano Vape Shops, and we have late testimony from Hawaii Smokers Alliance, Retail Merchants of Hawaii, and a number of individuals in opposition and support. I want you to know that all your testimony has been submitted for the record. Anybody has any questions? Representative Ward?
Sure. Sorry, I'm a little bit late today. Did any of the witnesses indicate what the price of the inspection branch foundation or formation would cost?
You can ask the Department of Health.
Department of Health, could you answer that question? What's the estimation to set up the inspection branch?
I'm going to have to defer respectfully, Representative, to the Attorney General's office, since this bill actually refers to the Attorney General's office to set up the inspection, if I may, Chair.
Yep, sure. Attorney General.
Thank you.
Because ultimately it goes to finance and they'll have to answer that anyway. So you might as well do it now.
Hi, I'm sorry, I do not have an estimate on what it would cost. My main concern is keeping it separate from the MSA enforcement, which we currently do. There's about 647 retailers right now that have certificates from us. There's over 1,000 retail tobacco permit holders that our investigators currently check. I do not have an estimate at this time, but I would look into it with my office and get back to you if that's acceptable.
As your experience rating is, one inspector can cover how many certified retailers? What's the coverage?
Well, I think we have 7 investigators right now. During the course of a year that's not a pandemic year, they go to all the major islands. And like I said, they hit over 1,000 shops between the 7.
So if 7 can do 1,000, 5 can do, or 4 can do 647. I'm just trying to get a ballpark.
That sounds like
Is a pandemic and a tight budget area? I'm just wondering, is this the time to do the inspection given the amount of money that this may be costing? Anyways, that's the question. Finance will probably drill down much more than I did. Thank you, Chair.
Thank you. Anybody else have any questions? Okay, seeing none, moving on to HB 476 relating to taxation. Department of Taxation.
Good morning, Chair. Jacob Hurlitz on behalf of the Department of Taxation. We'll stand on our written testimony requesting a January 1st, 2022 effective date and making some technical suggestions. I'm available for questions. Thank you.
Thank you. All right. Okay. Department of Health.
Thank you, Chair Yamane and members of the committee. Again, this is Lola Irvin representing Director Char. The department does stand in support of HB 476. We do recommend, though, that because of the evidence that we already have and the success of pricing and deterring youth use, in that youth use of cigarettes decreased from 20% in 2000 to 5.3% by 2019. And so we know that pricing really does work. And so we do recommend that there would be price parity with cigarettes, which this bill currently does not have. And so we recommend a 70% wholesale pricing for e-liquids and electronic smoking devices or e-cigarettes. And so we have provided amendments at the end of our testimony. Hopefully that will be helpful. Thank you, and we're available for questions. Thank you so much.
Thank you. Hawaii Primary Care provided comments. Aloha Care.
Good morning, Chair. Trish LaChica for Aloha Care. We stand on our testimony in support. Thank you.
Okay, thank you. Yeah, that's good. Thank you. Hawaii Substance Abuse Coalition provided testimony. American Heart Association, Blue Zone Projects, American Lung Association, Hawaii, are you on? No? Okay. I also have Campaign for Tobacco-Free Kids of Hawaii.
Yes, Chair Yamane, this is Liza Ryan Gill representing Campaign for Tobacco-Free Kids in Hawaii. And we would like to support this bill and just add a couple of comments that we're afraid that the new definition may not include disposable e-cigarettes, which have become the most popular items for our youth here on the islands. And that we suggest that it also supporting the comments from Aloha Care and from the Department of Health that we'd like to see parity with other tobacco products. Thank you so much for your time.
Okay, thank you. Hawaii Public Health Institute.
Yes, good morning, Chair Yamani, Vice Chair Tam, members. I'm Julian Lipsher, a volunteer providing testimony on behalf of the Coalition for Tobacco-Free Hawaii and Hawaii Public Health Institute. The coalition supports the intent and wishes to offer recommendations that would create parity between HB 476 and existing tobacco and nicotine prevention statutes. You have our testimony. So to summarize, the proposed recommendations apply the language in HB 993, which one includes the terms e-liquid and e-cigarettes within existing definitions of tobacco products in current cigarette and tobacco tax statutes. Two, it establishes the same tax of 70% on other tobacco products. And three, requires e-cigarette wholesalers to obtain a tobacco license and retailers a permit. It's important to note that reductions in usage are best attained when the tax is raised to a level similar to the tax on traditional cigarettes, where cigarette smoking among middle and high school students has fallen well below national averages. Further, studies point to a 7 times higher chance of getting COVID among e-cigarette users than those who do not use. And this is important because youth and young adults in Hawaii now have the highest COVID infection rates among all age groups and would best benefit from the proposed higher tax rate along with proposed definitions and permitting and licensing requirements. Thank you for the opportunity to testify.
Hey, thank you. Reason Foundation.
Good afternoon, Chair. My name is Guy Bentley. I'm from the Reason Foundation. We're a non-profit public policy think tank headquartered in Los Angeles. Thanks so much for the opportunity to give testimony today. You have my written testimony, but I just wanted to follow up with a few points that are sometimes missed in the discussion of e-cigarette taxation. I do see in the bill, which is very interesting, a recognition between open systems and closed systems and need for different approaches to taxation of both of those. Both pose the same level of risks or benefits. So it's very interesting to consult the industry on the benefits of different ways of taxing open versus closed systems. But I would also just like to add that a lot of research has been done on e-cigarette taxation over the last 2 years, most of it finding that e-cigarettes are direct substitutes for cigarettes and are a much less harmful form of consuming nicotine. An analysis of Minnesota's e-cigarette tax found that after they introduced the tax, it produced 32,000 more smokers than there otherwise would have been. We also know that e-cigarette adult consumers who have switched from smoking to vaping are much more price sensitive than smokers. Smoking is a very inelastic good, so you have to raise the price very high to get reductions in smoking. E-cigarettes, not so much. The dangers of price parity, putting e-cigarettes and other combustible tobacco products on the same level, is that you're taxing a much less harmful product the same as the most harmful product. So instead of a tobacco harm reduction approach to taxation, it's one of, I'm afraid, harm maximization. And that's the danger of price parity, of putting less harmful products than the most harmful product in the market, that is cigarettes. And you can refer to the American Cancer Society, the Royal College of Physicians, and others who have extensively found that e-cigarettes are safer than combustible cigarettes, and also they've been found to be the most effective way to help smokers quit. Thank you so much for your time.
Okay, thank you. Okay, Volcano Vape Shops. Okay. No, okay. Retail Merchants of Hawaii. Okay. I'll go, just let you know, we have a number of submitted testimony from entities like American Heart Association, Hawaii State Teachers Association, American Cancer Society, Action Network, and numerous individuals in opposition and support that have been submitted. Members, any questions? Okay, seeing none, we're going to be moving on to HB 477 relating to cannabis. Department of Health.
Good morning, Chair Yamane, Vice Chair Tam, and members of the committee. I'm Michelle Makata for the Medical Cannabis Dispensary Licensing Program. The Department of Health stands on its testimony commenting, and I'm here to answer any questions that the committee may have. Thank you.
Thank you. Okay. Hawaii Cannabis Industry Association.
Good morning, Chair. My name is Jacqueline Moore, testifying on behalf of HICIA. I am testifying in strong support of HB 477. This bill does address and enhances the medical cannabis dispensary program and infrastructure with additional facilities. This strengthens patient access by expanding legal channels for individuals that are accessing cannabis for medical use from other sources. These sources do include black market and gray market sources that are thriving right now in the state. Legal medical cannabis program really is only providing a fraction, 10% of the total cannabis consumed in the state. This bill addresses it by increasing those legal channels for folks that otherwise don't have either through geographical issues and access to clean, regulated, tested medicine. Second point is, in preparation for the expansion of this program, medically or otherwise, we need to have in place infrastructure and a capacity that have been tried and true, that essentially have met standards and regulation. The third point that this bill addresses is wholesale. And what wholesale does between licensees right now is it does promote a diverse pipeline of products that enables patients in every county to access formulations and strains that may not otherwise be available. This wholesale provision also provides a contingency plan in the event of a catastrophic crop failure. So access for patients in counties like Kauai, where there's only one licensee, there would not be theoretically a disruption of cannabis medicine for them. We do understand the legality of inter-island transport. We know that it's being discussed and is still unclear. Inter-island transport is already happening right now with the labs. Please refer to HRS 329-1222D3. Thank you very much.
Thank you. Okay, Big Island Grown Dispensaries.
Excellent. Thank you very much. Jacqueline Moore, CEO of Big Island Grown Dispensaries. I'll finish off where I left off with the legality of inter-island transport. Please refer to the provision that is allowed currently with labs. The last point that I'd like to address is the quantity allowed for wholesale between licensees. We understand the need to have a controlled mechanism and limits on quantities. 4,000 grams of manufactured product is extremely reasonable. 4,000 grams of flour equates to less than 10 pounds. This is really only a day supply for some dispensaries. We would love to work together and respectfully request that the committee consider increasing the amount only on the limit on flour. Please understand that there is logistics and risk involved every time we transport, and so the intent is to maximize the transports and limit the frequency of such transports. Thank you very much.
Thank you. Drug Policy Forum of Hawaii. Okay. Members, any questions? Okay, Representative Ward.
Thank you, Chair. The Big Isle Dispensary, I think the last testifier, did I hear you
Yes.
say that the black market is alive and well, or that it was taking a line?
Yeah.
Sorry?
Yes, that is correct. What we're finding now, and the black market's really been thriving here, especially on the Big Island, but one of the things that I'd like the committee to consider and at some point for the state to address is the fact that through grow, the home grow cards, which comprises a lot of the 329 cards, there's a stacking of cards right now where some of the largest grows in the state are actually not state licensed dispensaries. They are this hui of cards. So yes, it is alive and thriving.
What do you mean stacking?
So what happens is when you are a patient and you you want to grow, or instead of, you have the ability to grow up to 10 plants. When a patient can actually give this ability to a caregiver. And so what you have is you have caregivers that are growing for multiple patients and theoretically stacking these cards. I don't want to say to skirt the law, because certainly it's allowed to a certain extent, but what's happening now is it's flourishing.
Thank you for that. That's very insightful, because some of us were told that, hey, once we get the dispensaries, the black market's going to disappear or fade away or diminish and stuff. It doesn't sound like that's happened. Thank you very much for your testimony.
Thank you.
Thank you, Chair.
Thank you. Representative Aarp.
Thank you, Mr. Chairman. Can I have the Department of Health, Ms. Nakata?
Sure.
Good
Thank
morning,
you.
Nakata. How are
Good
you? Thank you for being here.
Good
I appreciate the Department of Health's comments, but I'd like to go through them with you carefully. So
Sure.
first and foremost, in your written testimony, you note that there is a fiscal impact should this measure go through. And specifically, what is that?
Primarily, if the legislature were to approve increases in the number of facilities that could be licensed, we would need additional inspection personnel. Right now, we have 2 surveyors for the program and 26 facilities, which we inspect at least every 8 weeks, once every 8 weeks. And we are trying to step up that frequency, because I would say in probably at least 50% of our inspections, we are finding violations of state statute or administrative rules. In addition to,
so each of those inspectors, each of those inspectors that is in charge of 13 dispensaries.
well, they're in charge of there's 8 licensees. So each inspector is in charge of the facilities for 4 licensees.
Okay. And then secondly, I note in your written testimony, you talked about the increasing the number of production centers and retail dispensing locations per license is not needed at this time. Could you please expand upon that? Could you elaborate?
Sure. So currently, as I mentioned, there are 8 licensees. Of the 8 licensees, only 3 has used their allotment of 3 retail locations, and only 3, a different 3, not the same 3, have used their full allotment of 2 production centers. So not even 50% of the current licensees have maximized their allotted number of facilities yet. So we just feel that this request is premature at this time.
And I apologize, Chair, I apologize. For those of us who are not familiar with this process in terms of the production centers and the actual retail dispensing locations, Ms. Nakata, can you just explain that? Because you're talking about 50% and not utilizing all of their allocation. For those of us who are unfamiliar, could you just explain that very quickly?
Sure, no problem. So each of the 8 licensees is allowed to have up to 3 retail locations and up to 2 production centers. Production centers are for the purpose of cultivation, manufacturing, and packaging of cannabis and medical cannabis products. And the retail locations are for the purpose of dispensing to our registered patients.
Okay. And then with respect to I was confused with your written testimony regarding the number of registered patients. So there are 30,847 registered patients in the state of Hawaii presently?
Correct.
As of December 31st, 2020?
Yes.
Okay. And do we know what the number of patients? Are you guys able to track the number of patients actually utilizing the retail dispensaries based on their cards?
Yes, so we do run that statistic on a monthly basis. And for calendar 2020, approximately 36% of registered patients made purchases from a licensed dispensary. And that statistic is has been pretty stable over the past 3 years.
Do you have any comparison between Hawaii and other states? Like, is that the norm? Is 36% somewhere in the norm, or is that low? Is that high? Or do you have no idea? I mean, you don't compare that information with other states.
I have anecdotal information from discussion with other state regulators through the Cannabis Regulators Association. And I believe that Hawaii's figures are on the low side. You know, as a whole, the Cannabis Regulators Association believes that has a strong belief that what we would like patients to do is encourage patients to utilize regulated, licensed sources as sources for their cannabis and their manufactured products.
Okay, thank you. And then Ms. Nava, one last question regarding the ending of your testimony, your written testimony. You say allowing licensed dispensaries to purchase cannabis or manufactured cannabis products from another licensed dispensary presents potential risk for the licensees. Can you please elaborate on that?
Sure, the department just has two concerns, one of which I guess Ms. Moore had mentioned previously, and that is the uncertainty of inter-island transport. You know, but the second thing is the industry is still fledgling, and we have significant concerns about the risk that they're taking should there be a loss. I mean, theft or, you know, confiscation of the product. Who's going to absorb the risk for that loss? It could be a substantial amount of money. You know, for the approximately 9 pounds per transaction, a 4,000 gram transaction of cannabis flower could run, you know, at retail, you're talking about potentially over $30,000 worth of product. And should that be a loss, you know, Hawaii's not experienced that type of thing yet, but there have been court cases on the mainland, and, you know, the insurance companies are pretty split. Some of them will pay their insureds for their loss, but there are some courts that have not. And, you know, that uncertainty raises a lot of concerns for the department.
Is there potential liability for the state then? Are you saying there's potential liability for the state in the event an insurance company would not cover such loss? Is there the potential for liability for the state?
I don't think that I've seen that in any of the litigation that I've looked at on the mainland, but I think our main concern is really for the industry. I mean, you know, so I think if anything, if this bill were to move forward, that would be something that we would recommend, that be very clearly defined in the statutory change, so that everybody understands, you know, when they're entering into this agreement.
Who would bear the risk in the case of some type of theft or loss?
Correct.
Okay, got it. Okay, thank you so much, Ms. Nakata. Thank you guys at the Department of Health. You guys are doing a wonderful job with this program. Thank you so much for your hard work. Thank you, Mr. Chair.
Okay, seeing none.
I have a question, Chair. Online.
Okay, Representative Percy.
Sure. Thank you, Chair. I had a question for the First Lady who was speaking, Jacqueline, I think, with the HACA.
Oh, Jacqueline, yes.
Jacqueline, sorry.
No problem.
You're on. Okay. Could you explain a little bit more about the weight? I didn't entirely follow that. And also, there were some interesting points raised in the previous one about dispensaries and not fulfilling, some not having 3. And could you talk a little bit about that? Because
yes, I think, thank you so much for the opportunity to actually discuss some, you know, it's really fundamental to the program since the inception of the program. And it actually starts a lot with the lack of banking infrastructure. So when this program started, and it's really plagued this entire industry this whole time, you know, people were capitalized in different ways. And so some, you know, they had the minimum and then a little bit, you know, additional to get their license up and running. I'm speaking from a place where, from Big Island Grown, we have fulfilled, and we're the first licensee to fulfill what we considered a mandate from the state, which is to build out the footprint for all 3 retail locations. We did that fairly quickly, I believe within 12 months, actually, all 3 of our retail locations opened up on the Big Island. What we're seeing now is that certain licensees, for various reasons, could be business decisions, you know, also their lack of ability to even satisfy the current demand with maybe 1 or 2 retail locations, and I'd like to get into that. They are probably looking for, I would imagine, getting to the point where they're cash flow positive to be able to devote the money to CapEx for this expansion. Because there's such low opt-in from patients currently, and I'd like to discuss that as well. But because of that, some folks were not able to satisfy and build all 3 retail locations, in as timely a manner as we'd like to see. What I don't want to happen is that the industry be held back as a whole because there are folks that are not able to do it. I would like to point out Big Island. You have 2 licensees here that have all 3 retail locations built out. Now, there are still underserved areas on the island, stretching from, Pahoa over to Ocean View. To do this quickly, because it is about immediate access for patients, it makes sense because we have been able to demonstrate the ability to do it and do it fairly quickly in comparison to some of the other counties. Be able to open up an additional retail location for these folks, these patients that are currently getting it from their neighbors or maybe have a caregiver going for them. I want to be really clear, both as a trade association and as an individual licensee, we do support a patient's right to grow for themselves. So that, when we start talking about a stacking of cards, what we're really addressing and would like the discussion to continue on is this gray market where it does feed into black market, and it's a real thing and it's going on and everybody knows about it, but nobody's talking about it. And so I hope to a minimum that this testimony stimulates that dialogue.
Oh, thank you. And then if you could just speak quickly about the weight, because
yes, if you can clarify your question on the weight, but may I also say something about the concerns the Department of Health has on
sure. And then
the loss.
The 4,000 gram thing is what I was.
Yes.
Because you were saying one's fine and the other wasn't. I didn't quite follow that.
Correct. So 4,000 grams of a manufactured product, we typically, and I'm going to use for an example, cartridges. We sell 0.5 gram and 1 gram cartridges. For a 4,000 gram quantity limit, that is a substantial and reasonable amount to satisfy demand it could be for a month for a patient population for any one dispensary. When you start talking about 4,000 grams for flour, when you do the conversion, 4,000 grams of flour equates to less than 10 pounds. So less than 10 pounds is less than a 1-day supply for certain dispensaries. As far as a loss is concerned, we take on the risk of loss every time we open our doors and operate, especially when we don't have a local bank and folks are required to literally transport large amounts of cash, well over $30,000, and taking trans-Pacific flights to deposit in a bank that's not in Hawaii. I think that is something we should be discussing, and I think it's way more of a risk than transporting product.
Thank you so much. Thank you, Chair.
Thank you. Right. Any additional questions? No, seeing none, moving on to HB 482 relating to cannabis for medical use. Attorney General provided comments. Department of Health.
Aloha, good morning. Again, Michelle Nakata for the Department of Health. We stand on our testimony in opposition, and I'm here to answer any questions that the committee may have. Thank you.
Okay, thank you. Just let you know, we have testimony provided by Hawaii Cannabis Industry, Big Island Grown Dispensary, Drug Policy Forum of Hawaii, and Maui Grown Therapies. Okay, members, any questions? Okay, seeing none, moving on to HB 1282 relating to the transition of the Oahu Regional Healthcare System from the Hawaii Health System Corporation into the Department of Health. Attorney General provided comments. Department of Health.
Good morning, Chair, Vice Chair, members. The department stands on its testimony and super strong support, and we stand by for any questions. Thank you.
Okay, thank you. Super strong. All right, thank you. University of Hawaii.
Chair, Calbert Young, Vice President for University of Hawaii. We can stand on our testimony. The university is supportive of the bill. Available for any comments. Thank you.
Thank you, sir. Okay, we also have Queens Health Systems.
Aloha Chair, Colette Masunaga for the Queens Health Systems. Will stand in our testimony and support. Mahalo.
Oh, awesome. Thank you. Okay, we have testimony provided by Hawaii Health Systems Corporation in support, Hawaii Health and Harm Reduction Center in support, and Hawaii Government Employees Association provided comments. Members, any questions? Representative Ward?
Sure. Department of Health or the healthcare system. What is the amount of the subsidy now? And if this bill,
Sorry,
if this bill passes, what would the expected new balance sheet look like?
Representative, that's a good question. I apologize. I don't have the exact numbers in front of me. That's something that I still leave to the Hawaii Health Systems Corporation, Oahu region. But I can get you those numbers today.
But ballpark, what did we subsidize last year or the year before? I mean, we usually
Altogether for HHSC, the subsidy for all regions was, I think, about $100 million.
$100 million. So
that,
Oahu,
I believe Oahu received about 14 million of that.
Okay, so
Representative, I apologize. There is Sean Sonata from HHSC on the line too.
Well, let's hear from him.
Please. So Sean, sorry about
Good
that.
morning. Good morning, Chair.
Go ahead. My fault.
No problem at all. Representative Ward, to answer your question, I believe our subsidy last year was approximately $18 million. I could be off by about $1 million, but that's what the Oahu region specifically requested last year. And I think it's very similar this year as well. But I can get you the exact numbers once the hearing is concluded.
So if this bill passes, does it go up or does it go down? That's the question.
And the anticipation is that initially it would stay roughly the same because our operations are not intended to change initially. The idea behind the bill is that we would be collaborating with the Department of Health to develop new programs. Some would be revenue generating and others would be just increased services for the community. With the onset of the revenue generating programs that we are currently working on, if they occur as we plan, then ultimately we expect the subsidy requests will go down over time. It's not going to happen immediately, but as we implement our strategies, we expect that they will eventually go down.
So the revenue generating strategies are to get more income, and peeling it off from the state system is to get more income. I'm trying to see what's your drivers here. Is it you're not getting enough income the way you're doing it, or you don't have enough jurisdiction? Is it governance?
Well, the back
talking about this thing and adjusting it for the last 15 years or so. And this is kind of one of the more bigger adjustments.
Right. So specific to the Oahu region, as you're aware, we specifically deal with long-term care, unlike the other HHSC regions on the neighbor islands. So because of that, we operate primarily as a safety net operation. 80% plus of all of our residents are on Medicaid. So the cost of their care as a daily matter exceeds the revenues that we generate from Medicaid are exceeded by the cost of their care for each particular resident on any given day. So because of that, we operate like a safety net, and we do need to develop strategies to obtain revenue other than from the healthcare. And so, as everyone's aware, Leahi Hospital Campus and even Malihia, we have some spaces that could be ideal for other business partners to join in on and generate revenues. And from that revenue, we anticipate we would be subsidizing some of our operational deficits. And in turn, we would be requesting less money in the long run from the legislature.
How will Leahi benefit you economically? What kind of a profit center would you make into that rather defunct hospital?
Well, our plan is not specifically to increase the long-term care operations that we currently hold. It's to enter into other business arrangements so that those revenue-generating businesses or partnerships will subsidize and preserve what we currently have. The anticipation, as stated in our testimony, is that within the next 5 to 10 years, there's going to be a shortage of about 1,100 long-term care beds. So we don't want to get rid of a service that we're currently providing, but we want to preserve that service. In order to do that in a fiscally responsible way, our plan is to generate revenue from the rest of the campus in other means that aren't not connected with long-term care.
Okay, from my first question, you said it's rather revenue neutral. You won't increase your subsidy, it'll be about the same. So what's the strategic advantage? Is it you feel better under the jurisdiction and leadership of the Department of Health rather than your own separate one? Or what's the attraction to go into the Department of Health jurisdiction or governance model?
Chair, if I might beg leave to answer part of the representative's question. This is Eddie. So Representative, the goal would be to, as Sean is talking about, the goal would be to increase revenues so that the fiscal burden on the state of managing those facilities are reduced overall, which is essentially was the sole purpose of creating HHSC in the first place historically. The other big part of the goal would be to coordinate the resources that are available both to the Oahu region and to the Department of Health, particularly in the Behavioral Health Administration, to manage and utilize those resources in a way that helps us reduce the overall incidence of homelessness, for example, in the state, as well as other psychiatric issues that we've been talking about the last couple of years. And so when we talk about things like stabilization beds and flow of patients through a continuum of care, then it just makes sense from our perspective to join forces and bring the two resources to the table.
Okay, Chair, last question. Back to Sean. Sean, why can't you do what you're proposing now without the Department of Health? In other words, this Leahi revenue generation, what's holding your hands from doing that now within the context of HHSC?
Representative Ward, to answer your question, I should go back a little bit. The plan and the goals that we're setting are twofold. So I think Mr. Mercero pointed out the second part of it. I mentioned the first part earlier, which was revenue generation. On the revenue generation side, I will admit that there are a number of projects that we can enter into with our current exemptions that we can do without the Department of Health. But equally important to the revenue generation is the increase in programs that through a partnership with the Department of Health, even being part of the Department of Health would be much easier. To give one primary example, we have a program at the Leahi campus going on right now. It started off as a pilot last year, or even a year and a half ago, and it's grown, it doubled in size, and the program itself treats people who have come out of the state hospital and then went into a, I guess you call it intermediate home. And then one step after that, before released to community, would be at Leahi's, on Leahi's campus. In order to create that program, it took several rounds of contracting, several rounds of approvals that had to intersect between two different jurisdictions. Had we been part of one jurisdiction, it would have been a lot more seamless to get the same project done. I'm not saying that it can't be done the way that things are now, but it'd be a lot easier to do it as part of the Department of Health jurisdiction. So going back, it's twofold. One is revenue generation, but it's also development of new plans to help the community.
Okay, Chair, I just got in with a statement that the reason why we formed HHSC years ago was to get revenue neutral, like they're going to make themselves as a profit center to get out of the subsidy. We still haven't got that. So
Yes,
this
I'm
looks
familiar
like
with it.
something
Yes.
ironic. So thank you, Sean. Thank you, Chair.
Okay, any other questions? Okay, Chair has questions for HHSC, Sean, and Mr. Mercero from Department of Health. We've been working on this for a number of months now. Is that correct that there was language, I guess not compromise, but language developed in regards to how the transition would conceivably happen?
Yes, Chair, that's correct. We've been working, we have been working on this for a number of months collaboratively, and want to make sure that a transfer of this nature happens with all parties involved, with all stakeholders involved, and in a way that is ultimately beneficial to the state as a whole.
Okay. Mr. Sonata, does the transfer language being that was worked out as of yesterday protect and support the employees of the HHSC system as requested by HGA?
Yes, we believe that it does. And, you know, as we move forward, I think in HGA's testimony, they explained and in their comments that they anticipate there will be more changes that might need to happen or some negotiation or consultation. And, you know, we've been very transparent with them as well as UPW in the last session as to what we anticipate to happen and the protections we plan to implement for all employees. This is both unionized and not. Because we want it to be seamless and not adversely affect any employees moving forward. So yes, all of those issues have been addressed and we will continue to address them as new ones pop up.
Because that was a priority of the chair, right? To make sure people are protected, as well as my understanding is the language in regards and the respect given to the University of Hawaii as the landowners are still maintained. Is that correct? Moving forward?
Yes, Chair, it is.
In all future discussion. Okay, so the chair did want to highlight for members that the current bill does also allow the opportunity for Department of Health as well in this new form to look at various revenue-driven opportunities. Is that correct?
Yes, Chair.
Okay, and those revenue opportunities could immediately be drawn down to, for example, like capital improvement projects as well as long-term mixed use for the both Malohia and Leahi.
Yes, Chair. Correct.
Okay, good. With potential federal drawdown, right? Okay.
Yes.
I just wanted to verify, just in case people were questioning what the intent and then why the language of the bill was drafted the way it is. Okay. So
Yes.
Members that are paying attention, just as of yesterday, less than 20, maybe 24 hours ago. So my understanding is HHSC as well as Department of Health crafted mutually agreed upon language. Thank you. Moving on to HB 1322 relating to trauma-informed care. Department of Health.
Good morning, Chairperson Yamane and committee members. The Department of Health is in strong agreement with this bill. It is not enough to have individuals who understand trauma-informed care, but we need the greater system to know how to respond in a trauma-informed manner when it conducts business with the public. A task force can go a long way to assist our statewide system with how to apply trauma-informed knowledge. Please understand that the trauma-informed care goes well beyond healthcare and applies to education, the judicial system, law enforcement, policymaking, among other things, in creating a more responsive and effective system across the lifespan that promotes the resiliency of our communities. Thank you for your time.
Okay, thank you. Moving on, Department of Human Services.
Good morning, Chair, Vice Chair, committee members. Joseph Campos, Deputy Director of Department of Human Services. We stand on our testimony and provided comments. Thank you.
Okay, thank you. We have testimony provided by Daniel Goya.
Good morning, Chair and committee. I'm submitting this testimony in strong support of this bill. Adverse childhood experiences, which really have affected our communities, are linked to preventable health diseases and chronic mental health problems. COVID-19 can be seen actually as an adverse childhood experiences, and the impact that it will have on our children and their children will be immense. I think putting this task force together can explore opportunities so that there can be an interagency and shared community response by nonprofits and community organizations as well to address the needs of trauma in our community. Mahalo for your time and consideration.
Okay, nice to see you again, Danny. Okay, members, there's testimony submitted by a number of entities from the Executive Office of Early Learning, Office of Hawaiian Affairs, County of Kauai, Vibrant Hawaii, Hawaii Primary Care Association, Hawaii Kids Can, Hawaii Children Action Network, Hawaii Youth Services, Kamehameha Schools, Hawaii Health and Harm Reduction, Hawaii Pacific Health, Papa'ola Lokahi, and a number of individuals all in support. Members, any questions? Okay, seeing none. moving on to HB 718 relating to health, Department of Labor.
Good morning, Chair Yamane, Vice Chair Tam, and members of the committee. This is Anne Ferrer, Eustaquio from the Department of Labor. The department offers comments on the measure and defers to the Department of Human Services on its ability to provide the information as outlined in the proposal. We stand on the rest of our written testimony, and I am definitely available for comments or any questions. Thank you.
Thank you. DHS, MedQuest Division.
Good morning, Chair, members of the committee. This is Judy Moore Peterson, MedQuest Division Administrator. We stand on our written comments and our testimony. We defer to the Department of Labor regarding the agreements and getting that data, as well as to the Attorney Generals. Thank you.
Okay, thank you. Okay, we have comments provided by the Attorney Generals as well as Civil Beat Law Center for Public Interest. Members, any questions? Okay, seeing none, moving on to HB 576 relating to healthcare. I have here DCCA.
Good morning, Chair. My name is Leanne Tashima, Executive Officer for the Board of Nursing. The board supports this bill to the extent that it authorizes advanced practice registered nurses to perform certain abortions and also requests amendments. The board notes that amending Hawaii Revised Statutes Chapter 453 will necessitate amending HRS Chapter 457, which is the Nurse Practice Act. However, to avoid uncertainty about which chapter or board controls the ability for APRNs to provide this service, the board recommends deleting all references to advanced practice registered nurses and Chapter 457 that this bill proposes to place in HRS 453. We also request that add the following language in the Nurse Practice Act to allow advanced practice registered nurses to perform the abortions, which states, notwithstanding any other law to the contrary, an advanced practice registered nurse may perform an abortion by medication or aspiration in the first trimester of pregnancy, so long as the nurse has prescriptive authority, practices within the nurse's practice specialty, completes a board-approved specified training program that includes a clinical component, and has a valid, unrevoked, and unsuspended license obtained in accordance with this chapter. We also recommend deleting lines 14 through 15 on page 5. Thank you for the opportunity to testify and for the committee's consideration of our proposed amendments. Thank you.
Okay, thank you. Hawaii Life Alliance. No? Okay. Hua Moon Women's Health LLC. Okay. Planned Parenthood.
Good morning, Chair Yamane and members of the committee.
Okay, please proceed.
Planned Parenthood in both Northwest and Hawaii submitted written testimony in strong support of HB 576, which seeks to ensure that all people in Hawaii have equal access to abortion care, no matter their income or where they live. Please note that we also submitted with our testimony the names of 119 supportive individuals from across the state who would like their support to be documented. We're also joined today by a number of young people who will share with you a few of the myriad barriers that stand between people, particularly those on the neighbor islands and reproductive health care in Hawaii. As a healthcare provider, we care deeply about ensuring that our patients receive the care that they need when they need it. And that also goes for our brave and selfless doctors, nurses, and health center staff. Limiting access to abortion care, particularly during a pandemic, endangers their safety and incurs great costs for all, including the state, as they are forced to travel between islands to receive and provide care. Qualified licensed providers like APRNs and PAs can provide early in-clinic abortion just as safely and effectively as doctors, which is why states across the country are eliminating unnecessary barriers to abortion care. and we look forward to seeing Hawaii join that growing list. This bill will help to keep us all safe by allowing qualified and more widely available APRNs and PAs to provide timely, safe, and local care. Thank you for hearing and supporting this important bill.
All right, thank you. ACLU of Hawaii.
Good morning, Chair Yamane, Vice Chair Tam, and committee members. My name is Wookie Kim, and I'm here on behalf of the ACLU of Hawaii. We strongly support HB 576, and we also believe that its passage is necessary for Hawaii to comply with the federal and state constitutions. The current physician-only restriction is legally suspect for two reasons. First, it raises equal protection problems. The restriction is irrational because it unfairly targets and prevents certain healthcare providers who are just as qualified, experienced, and knowledgeable from providing early in-clinic abortion care. There's no justification for this differential treatment, especially when the scientific evidence is clear that APRNs and PAs can safely provide that care. Second, the restriction raises constitutional privacy concerns. The restriction imposes a substantial burden on abortion access and does so without furthering a compelling state interest as required by the Constitution. The burdens imposed by this restriction are clear. By limiting who can provide care, the restriction reduces access. But the burdens are also amplified by other factors, including Hawaii's unique geography as an island state, Hawaii's ongoing physician shortage, and the fact that we're in the middle of a devastating pandemic. And of course, these burdens also disproportionately harm people who already face systemic barriers to care, including Black, Indigenous, and people of color, low-income people, and people who live in rural areas. And finally, I would point this committee to a recent lawsuit that the ACLU filed in Maine challenging a similar physician-only restriction. Shortly after that lawsuit was filed, Maine passed a law very similar to HB 576. And I apologize, we actually cited the wrong case in footnote 6 of our testimony. That case is actually Jenkins versus Lynch. And again, I apologize for that error. And with that, we ask that the committee pass HB 576. Thank you.
Great, thank you. Lauren O'Connell.
Aloha, and thank you for this opportunity to testify in strong support of House Bill 576. I'm a communications and Chinese double major at UH Manoa, and as you will have learned in my written testimony, my mother was denied access to the care she needed following her miscarriage due to accessibility issues. I bring this story from Kentucky in the 90s to your attention today because it's relevant to the experiences of many women on our neighbor islands, even in 2021, in this progressive, open-minded state, which has historically been in support of access to abortion. Abortion is often a time-sensitive procedure, but on the island of Maui, which has no providers, women are forced to wait several weeks for abortion providers from Oahu to travel there for their care. This issue of accessibility has disproportionate impact on our Native Hawaiian communities and communities of color. As an aspiring communicator and someone with understanding of language barriers, I know that allowing local APRNs to perform abortion procedures would increase accessibility by increasing awareness of how to get the procedure, which ultimately will save lives. Mahalo nui for your time.
Thank you. Jessica Connor.
Aloha Chair and Health Community. My name is Jessica Connor from the Big Island of Hawaii. I'm a social work student at the University of Hawaii at Manoa and a lifelong advocate for women's reproductive health. Today, I am here in strong support of HB 576. In my written testimony, you can see how difficult assessing abortion care was for my friend. The process from the beginning to the end filled her with obstacles and closed doors. With the cost of living so high in Hawaii, many residents are pushed out to rural areas that lack resources like public transportation. For a patient to live in areas such as Ka'u or Kohala, being subjected to travel to a neighboring island like Oahu can cause a lot of stress, as Oahu is fast-paced and kind of intimidating. Upon her return home from receiving abortion services in Oahu, she was met with anger and aggression from her partner. Her situation left me wondering how many other women are in similar situations. By pushing this bill forward, you will make it possible for women in any style of life to feel like they will be able to get access when needed without going through stressful and extensive hurdles. Mahalo nui Chair Yaname and the Health Committee for taking the time to listen.
Thank you. Emma Ishihara.
Good morning, Chair, Vice Chair, and members of the committee. My name is Emma, and I'm testifying in strong support of Bill 576 to allow APRNs and PAs to provide medication and aspiration abortions. This procedure has been shown to be safe and well within the scope of practice for APRNs and PAs. I'm currently studying social work at the University of Hawaii at Manoa as well, and it's extremely concerning to me that neighbor islands, especially Molokai, do not have equal access to healthcare services, especially reproductive healthcare services. On Molokai, birth control is largely unavailable due to a lack of supply at the single women's health center that exists on the island. There are no abortion providers on Molokai, so residents are forced to go to Kahului, Maui, or to Oahu in order to receive care. This ferry that would normally carry them from the island to Maui is currently closed due to COVID concerns, and there are people who are forced to book flights instead, which carry the potential to infect them with COVID-19 and are frequently delayed or limited. Additionally, due to perceived stigma against abortion care and a lack of protection for survivors, there are a shortage of abortion providers in the state. On Maui, in-clinic abortions only scheduled twice a month, and providers must travel from Oahu, which significantly limits appointment times for this very time-sensitive procedure. Not only is it difficult to make the decision, but time and money that it costs to go through with it puts emotional toll on everyone, especially those who are living in poverty or from minority groups on the outer islands. We need to expand these vital procedures by allowing more people who are qualified to do their jobs. This bill would especially benefit our residents on the neighbor islands who suffer from a lack of access to general health care, as evidenced in our recent experience with the COVID-19 pandemic. Thank you so much for this opportunity to provide testimony for this important piece of legislation. Have a nice one.
Thank you. American United for Life.
Thank you, Chair. My name is Katie Glenn, and I serve as Government Affairs Council of Americans United for Life. Established in 1971, we are a national law firm with a specialization in abortion, end-of-life, and bioethics law. Thank you for the opportunity to testify in opposition. This bill would strip Hawaii women of one of the few existing health and safety protections they have left under state law and take Hawaii far from the mainstream. I've submitted written testimony for you, but I'd like to point out that abortion is a surgical procedure that can lead to numerous and serious medical complications. The question here is not whether an APRN may be able to perform an aspiration abortion where nothing goes wrong, but whether that they have the ability, the competency, and the training to deal with many types of complications, including very serious complications requiring emergency transfer that can arise. This is the very reason Hawaii currently requires abortion to be performed by a licensed physician or surgeon alongside 37 other states. States do this because women need cohesive care. They need care that's time sensitive and that can get them to the emergency room, that can get them admitted, which there's some question to whether APRNs are able to admit women into a hospital or whether they need a physician to do that. Please consider these things and consider how far outside of the mainstream Hawaii would be from other states if you pass this bill. Thank you.
Thank you. There's a number of entities and individuals that provided testimony in support and opposition. It'll be noted in the record. Members, any questions? Rep. Ward?
Thank you, Chair. Planned Parenthood, please. I have a numbers question regarding accessibility. For those who have been required to fly to Oahu for their abortion, do you have any numbers by island or as a whole?
Planned Parenthood is not the only provider in the state, so I can't give you a great number, but I can tell you that about 10% of our patients have to travel between islands.
Sorry, I think it was garbled. I didn't understand the last sentence.
And I said about 10% of our patients have to travel between islands.
About 10 in how many? 10% of how many patients?
I don't have that number for you. Sorry.
Okay. Who actually keeps the statistics on abortions in Hawaii? Is it the Department of Health? Do we have any numbers of what the numbers are? Health? Do you have
I don't. I'll have to defer to the Department of Health.
Are they still on? Hello, Department of Health, not on. Okay. Maybe the last question then is, are they going up? Or are they going down? And what number of states actually have this bill as part of their governance model of reproductive health? Hearing none, Chair, I guess I
Okay.
get it. Thank you.
Representative Capella.
Thank you so much, Chair. My question is actually for Lori Field from Planned Parenthood. And it's an access question. I think I'm the only Neighbor Island legislator on the committee, and I'm also a young woman who has utilized Planned Parenthood services. My questions, considering that my district is very rural, one of those very rural communities, Kona and Ka'u, specifically, if this bill were to pass, which I hope it does, how much will this expand access across our state?
Well, that's a great question. We hope that it will ensure that folks are able to get the care that they need in their local communities. We do know that APRNs are widely available across the state, more so than physicians, and that they deeply care about this issue as well. And so I noticed in the written testimony that there are quite a number of healthcare providers who support this bill and are very encouraged by the idea that folks would be able to receive community or care in their own communities.
Thank you. I appreciate that. And I appreciate all of the people who testified today. On the Big Island, there is no access currently. So I'm hoping that this bill will change that. Thank you, Chair.
Okay, thank you. Vice Chair.
Hi, aloha. My question is for Wookie Kim at ACLU.
Yes, Vice Chair.
Yes. So my question is about litigation. Does Hawaii face any potential litigation on this bill?
In short, yes, we think so. We believe that Hawaii's current restrictions are very much like the main physician-only restriction that we challenged. And as I stated in both the written testimony and the oral testimony today, we believe that the state faces potential litigation risk.
Thank you so much.
Thank you.
Okay. Oh, any other questions? Okay. Seeing none. Okay, moving on to HB 988 relating to services for Kupuna, Department of Health.
Good morning, Chair Yamane, Chair Tam, Vice Chair Tam, and members of the committee. My name is Caroline Karirao. I'm the Director of the Executive Office on Aging and attached agency to the Department of Health. We stand in strong support of House Bill 988 and would like to offer an amendment. This bill allows for additional flexibility and increases support to both Kupuna and their caregivers. The amendment we'd like to offer is to delete the term unemployed caregivers, which is, I believe, on page 9 of House Bill 988. And I'm available for questions. Thank you for the opportunity to testify.
Thank you. Department of Human Services.
Aloha, Chair and committee members. On behalf of the Department of Human Services, I'm Daisy Hartsfield, the administrator for the Social Services Division. The department did provide testimony in support, so we'll stand by that written testimony, and I'm available for questions as well as the administrator for the Adult Protective Client Services branch. Thank you.
Okay, thank you. AARP.
Good morning, Chair. This is Audrey Nakagawa. I am the Advocacy Director for AARP Hawaii. We stand in support of this bill, which allows program flexibility to allow caregivers who are working less than 30 hours to continue to qualify for this program. We will defer the recent amendment made by the Executive Office on Aging, but again, we do support this bill. Thank you very much.
Okay, thank you. Alzheimer's Association of Hawaii. Mr. Ross?
Hello, Chair. I'm not sure if you can see me.
Yeah, okay, go ahead, please proceed.
All right, thank you very much. The Alzheimer's Association is in support of this bill and will stand on our written testimony. I'll just say that we're not opposed to the amendments that we heard from the Executive Office on Aging. Thank you very much.
Okay, thank you. Okay. For those present, there's a number of individuals and entities that provided testimony, all in support. It'll be noted. Members, any questions? Okay. Seeing none, members, you guys are quite efficient. We expected a lot of testimony. We will be taking a recess to do decision making on these measures following the joint decision making with pandemic committee at 11 o'clock agenda. Okay, in this room, yes.
This room today, 11 o'clock.
Yes. Okay. Okay. All right. We will be recessing. Thank you.